We're going to begin the session, though, with a tribute to Hardy Hendren, who all of us know needs no introduction, former president of APSA. This is a presentation performed by Brendan Levasek, so please enjoy.
Through a celebrated pediatric surgical career spanning over 6 decades, Hardy Hendren has impacted countless lives, including healing thousands of patients and training dozens of surgeons. His advancements have revolutionized the care of pediatric surgical patients, and he is honored worldwide as an icon in pediatric surgery. William Hardy Hendren III was born in New Orleans in 1926. His family moved to Kansas City when Hendren was 8 years old, and where he was first exposed to the field of surgery. Hendren attained the rank of Eagle Scout and graduated as class valedictorian at the Woodbury Forest School in Virginia. He enlisted in the U.S. Naval Aviation School in 1943 and qualified as a naval aviator in 1946 at the age of 20. He met his wife Eleanor the following year. Hardy and Eleanor would have 5 children, 3 of whom are surgeons. Following his military service, Hendren completed his undergraduate education at Dartmouth University, graduating cum laude in 1948. He then completed his medical education at both Dartmouth and Harvard medical schools, where he was first exposed to pediatric surgery during a month-long surgery elective with Robert Gross at Boston Children's Hospital. During his time at Harvard Medical School, Hendren led the creation of the National Student Internship Matching Committee, the process that is still used today across the United States for graduating medical students in their residency matches. He graduated cum laude from Harvard Medical School in 1952. Hendren began his surgical training as a resident at the Massachusetts General Hospital under the leadership of Edward Churchill. During his residency, he performed a 2-year pediatric surgery fellowship at the Boston Children's Hospital from 1955 to 1956. He completed his surgical residency at the MGH in 1958, followed by a chief residency at Boston Children's, finishing in 1960. Hendren then joined the staff of the Boston Children's Hospital, but a rift between Hendren and his mentor, Robert Gross, pushed Hendren out. He was recruited back to the MGH in 1960 to lead the creation of the MGH's Pediatric Surgical Service as the chief of pediatric surgery. During this time, Hendren would pioneer novel surgical approaches for congenital urogenital malformations, including megaureter, urinary undiversion, and cloacal abnormalities that were otherwise previously untreatable. Hendren's influential approaches are still heralded today as the major revolution in urogenital surgical care. In 1974, Hendren and Gross would reconcile at a meeting of the American Surgical Association. Hendren would later be named the inaugural Robert E. Gross Professor of Surgery at Harvard Medical School, a position which he held for 15 years. Hendren rejoined the Boston Children's Hospital as the chief of surgery from 1982 to 1998, where he would personally train 16 fellows, all of whom went on to impactful careers and to become leaders in pediatric surgery. Hendren's surgical career would be honored with awards and commendations from many of the major societies, including the American Academy of Pediatrics, the American Urological Association, and the American College of Surgeons. He was honored by the American Pediatric Surgical Association as an APSA charter member, was elected to serve as its president from 1981 to 1983, and was commended with the APSA's Distinguished Service Award in 2007. Today, Hendren remains active in pediatric surgery as the leader of the Hendren Project, an international surgical collaborative for healthcare providers in pediatric surgery and urology. It is altogether fitting that the APSA's 50th anniversary meeting convenes in Boston, the city where Hardy Hendren's dedicated and faithful service to the pediatric surgical community would grow and flourish. The American Pediatric Surgical Association honors his inspiration as a surgeon, mentor, leader, and friend to pediatric surgeons and children worldwide.
Thanks everybody for waking up early, especially those of you like me from the West Coast. It's only 4:30 in the morning. Today we're going to talk about two topics that we're doing systematic reviews on. We have Julia Grabowski, Rojni Dasgupta, Akimi Kawaguchi, and Ashka Sain. We're going to be talking about the effects of anesthesia on neonatal brain development, and we're going to be talking about long segment Hirschsprung's disease. Some of the things that we've learned along the way in the last several years of doing these systematic reviews is that there are lots of variability in the definitions of the things that we do. We've also learned that as we do them, as you will see, it's very difficult to come up with some good consensus statements because of this variability. So one of the things that we've moved to over the last few years is to try to come up with some common definitions of things and really try to get those messages out to the membership so that as we continue to publish and do some research, we're doing it with our collaboratives with common definitions. The difficult thing, though, that we all know is that it can take 20 years for things to come from research to how we actually practice medicine. I think the Harman Ponsky session last night was a very entertaining but good example of how there can be such variability and some very strong opinions about how we should care. And so being open-minded and figuring out how we implement these things is also extremely important. Moving forward, one of the things that we're going to be doing more and more is some collaboration between the Outcomes Committee and the Quality and Safety Committee, so that as we come up with the data, the systematic reviews, and then ultimately as we're moving more into creating some guidelines so that we can help people to really understand and decide what would be the best in certain situations like spontaneous pneumothorax, and come up with guidelines of what we recommend would be the best based on the resources available at different institutions of how we should care for esophageal atresia. That as we come up with these guidelines, we can figure out some tools for how we implement these in different institutions across the country, because we all have different resources. And so the Quality and Safety Committee has come up with a really remarkable toolkit that everyone has access to, and it's easy to get to. And there will be more discussions about that. The Outcomes Committee is involved in several systematic reviews. We don't present all of them. Some of them go straight to publication. We're also, in addition to these, currently working on opioid reduction and intussusception, anal rectal malformations, and how to care for ulcerative colitis. So there's a lot of work still in line. And as Dr. Powell has mentioned, with all of the practice gaps, we got a lot of work to do. So without any further ado, I want to introduce Julia, who's going to begin with our first systematic review.
Thank you. Good morning. So there's been a lot of concern over the past several years about the role and the risk of general anesthesia on the developing brain. This comes primarily from animal data, which has shown that sedatives and anesthetics in young rodents and mice can lead to nerve cell death, later abnormal behavior, and nerve cell apoptosis. In 2016, the US FDA released the following warning that repeated or lengthy use of general anesthetic or sedation drugs during surgeries or procedures in children younger than 3 or in pregnant women during their 3rd trimester may affect the development of children's brains. Many groups, including ACS, AAP, and others, have responded to this warning, and several task forces, including most notably Smart Tots, have been developed to study this topic further and develop human data-driven recommendations. The goal of our systematic review was to review current available literature to better inform us as we talk to other practitioners and families. The Outcomes Committee agreed on the following 4 questions. Does general anesthetic exposure in children pose a risk to their neurodevelopment, and is this risk dose-dependent? Is there a critical window of neurodevelopment during which anesthesia exposure should be avoided? Does exposure to specific anesthetic agents carry more risk than others, and are there certain agents that can be added to decrease neurotoxicity? And what are alternatives to general anesthesia in children, and what is their data for their safety? Using the usual databases, we searched relevant search terms, including all dates up to the end of 2017, ages 0 to 4 years old. We found 493 abstracts and then reviewed 56 articles. We put these into 4 different slots. Some articles were used for multiple questions, and then we used any follow-up articles from the articles in the original search. We then looked through, graded them on basis of levels of evidence, and made a consensus statement of recommendations in response to each study question. We found many limitations when we did our study. First, that these were predominantly retrospective and observational studies, and many different age groups were included. The endpoints varied between studies, and there were different measures of neurodevelopment, cognitive studies, et cetera, in each study. There was limited detail on type or duration of anesthetic agents given in many of the studies, and in most of the studies, there was no control on the indication or outcome of the surgery, including perioperative trauma and postoperative pain management. For question number 1, there were 26 studies, including 24 looking specifically at generalized neurodevelopment and 2 looking at anesthetic duration. The neurodevelopment tools that were utilized included the Bayley Scales of Infant and Toddler Development, Wechsler Preschool Primary Scale Intelligence, 3rd edition, Full Scale Intelligence Quotient, or IQ, and other measures including test scores, preschool language scale, and questionnaires or surveys. Probably the most robust trial so far has been the GAS trial, which is a multi-centered, randomized control trial comparing regional anesthesia to general anesthesia in infants undergoing inguinal hernia repair. The primary outcome was recently reported in 2019, and that looked at IQ score at age 5. However, the secondary outcome was reported in 2016, and this was an intention to treat analysis. 361 infants were randomized to receive regional anesthesia, with 358 to GA. 69 of the regional patients then required the addition of general anesthesia, and the average duration of SIVO was about 54 minutes. In the first study, looking at Bayley score at age 2, the authors found that there was no evidence that less than 1 hour of SIVO anesthesia in infancy increases the risk to neurodevelopmental delay at age 2 compared to awake regional anesthesia. This was followed up then by looking at the primary outcome at age 5, and this was reported again, as I said, recently in 2019. They found 205 of the regional patients and 242 of the general patients. And the endpoint was the full-scale IQ on the Wechsler Preschool and Primary Scale quota at age 5. Again, they found that there is no evidence that less than 1 hour of SIVO increases the risk to neurodevelopment at age 5. Another study that's been talked a lot about is the PANDA study, which is a prospective study of siblings between 2009 and 2015. There were 105 sibling pairs, one exposed before the age of 36 months. Inhaled general exposure was about 80 minutes, an average between 20 and 240 minutes. And then they did IQ testing at age 8 to 15 years old. The conclusion of this study was that there is no statistically significant differences in either mean IQ scores or domain-specific neurocognitive functions between exposed or unexposed siblings. There were 2 studies looking at a cohort of neonates who were operated on before 90 days old. They were enrolled at the time of surgery, and for the first study assessed at age 1, and the second study is assessed at age 3. The surgical outcomes at 1 year, the surgical infants scored lower on 4 of the 5 scales of the Bayley score, but these were only mild or moderate delays, and they were still in the average range. 2 years later, the surgical group still had lower scores on cognition, receptive language, and fine motor skills. However, there was no difference between the surgical and non-surgical patients, or babies, in physical activity. 3 other studies looked specifically at infant exposure to general anesthesia. 2 found lower verbal scores and a lower overall neurocognitive test at age 24 months or 5 years, while 1 found no difference between groups at an average age of 12 months. There were 2 sort of interesting studies looking at siblings or twins. The DiMaggio study in 2011 looked at a matched birth cohort of an exposed and unexposed sibling. There was no data on type or duration of general anesthesia. And the risk in the exposed group was 1.6 of behavioral problems or developmental delay. However, in matched sibling pairs, this was only 0.9. The twin study by Bartels et al. Looked at twins, 1 exposed, 1 unexposed, and found that the exposed group had a lower overall educational score and more cognitive impairment than the unexposed group. However, when you looked at twins, there was no difference in the scores between twins. And the authors of these 2 studies suggested that perhaps this excess risk of neurodevelopmental or cognitive difference is unrelated to the general anesthesia or surgery. 3 other studies looked specifically at neurocognitive test scores in school-age children or teenagers. 2 found that there were lower scores in certain domains. However, 1 found no difference in cognitive outcomes between 1, 0, or greater than 1 anesthetic exposure. Many studies have looked at academic performance with many, many patients. 3 found no difference in national test scores between unexposed and exposed kids, and 2 found slightly lower national test scores. 1 showed a much higher rate of formal diagnosis of learning disability. However, this was based on phone interviews with families. As far as learning disabilities and ADHD, there's a retrospective cohort in Minnesota that had been anesthetized between 1976 and 1982, as patients were then assessed for learning disability or ADHD. The authors of the study found that multiple anesthetics, but not a single anesthetic, increases the rate of learning disabilities or ADHD. Followed up several years later in 2017 using a quote-unquote modern anesthetic technique, these authors again found that multiple exposures, but not a single exposure, increased the rate of learning disability, ADHD, and academic impairment. As far as autism, which is a lot brought up by our patients and their families, is that in 2015 there was a matched cohort study looking at greater than 5,000 exposed children. There was no increase in the diagnosis of autistic disorder in the exposed groups and no association between number of exposures or the development of autism. As far as duration, there were two studies that looked specifically at this. One was looking at 70 patients who underwent cranial vault surgery. The authors found an inverse relationship between length of exposure to cognitive scores at 36 months, but found that an additional anesthetic did not have any effect. Another study by Ng looked at almost 150 patients who had been exposed to anesthesia before age 3. They found that those exposed for less than 35 minutes had no difference from an unexposed cohort, but greater than 35 minutes, those patients had lower language scores. In conclusion, though the data is mixed, the most robust studies suggest that a single anesthetic agent does not have significant effects on general neural development, academic performance, or the development of ADHD or autism. And general anesthesia does not need to be avoided in childhood. However, practitioners should try to avoid prolonged or multiple anesthetic exposures. For question 2, there were 7 studies. In terms of the timing of anesthesia, an observational cohort study looked at patients operated on for isolated cleft lip, and they found that there was no difference in IQ between those patients operated on at less than 8 days old or between 3 and 10 months old. However, those operated on earlier had improved psychosocial development. A similar retrospective cohort looked at patients operated on for either cleft lip and palate, or cleft palate. An older age at repair had a lower academic performance, suggesting that potentially oral cleft type, not timing of anesthetic exposure, leads to different academic outcomes. Ng et al. Looked at patients who were exposed to anesthesia between ages 3 and 5 or 5 to 10 years old and found that there was an overall lower motor function in all exposed patients, but there was no difference in language or cognition between any of the groups, and there was no difference in outcomes whether you were operated on earlier or later. Kaufman et al. Sent a questionnaire to parents about behavioral development of their children who had been operated on either before 2 years or between 2 years and 6 years. And in this questionnaire, they found an increased risk of clinically deviant behavior in those patients exposed at a younger age. Finally, 3 other studies looked at different time points of general anesthetic exposure. The first one looking at almost 40,000 patients who were operated on at 11 different time points. These authors found that there was a minimal increased risk of developmental delay, ADHD, and mental illness in all ages, and there was no difference between the age groups. Another study looked at less than 2 or greater than 2 and found that there was an overall difference, small difference in those patients who exposed compared to an unexposed cohort. However, that was only in patients who were operated on at greater than 2 years old at the time of surgery. And finally, another study looked at patients operated on between less than 2 or 2 to 4 and found that there was no increased risk in those patients operated on at less than 2 years old, but a slight increased risk of developmental delay in those patients operated on between 2 and 4. In conclusion to question 2, data suggests that anesthesia may affect different domains of development at certain ages, but there is no conclusive data to support waiting until later in childhood to perform procedures under general anesthesia.
Okay, so I'm Roshni. So we're going to talk a little bit about the last two questions. So the first one is, does exposure to specific anesthetic agents carry more risk than others with regards to neurodevelopment? And are there specific agents that actually might mitigate risks? So there are 4 studies that really looked at this, and they all deal with certain specific agents that we're all pretty familiar with: ketamine, SIBO, nitrous, and TIVA. So let's talk specifically a little bit about the first agents. The agents, so ketamine is a very common anesthetic. It was first synthesized in 1962 for anesthetic purposes. We see it used very commonly in the operating room and in the emergency room. It has a very short duration of action. The thing to remember about it is that it is an NMDA receptor antagonist. So NMDA receptor activation is critical for the induction and the maintenance of pain perception. There is some controversial data as to whether ketamine is actually neuroprotective or neurodegenerative. There is animal data that exists that shows that a single dose of ketamine may be neuroprotective. And this is thought to be because it's able to decrease calcium entry into the neurons, which is mediated by NMDA, and prevent apoptosis. So one study looked at this. Buddha, in 2012, developed a prospective, randomized, placebo-controlled study for patients that were undergoing VSD repair. The ketamine dose in this study was 2 milligrams per kilogram. What they looked at is inflammatory markers at 6, 24, 48 hours post-surgery. They looked at MRI imaging, and they did the Bayley Infant Developmental Scale, both pre- and post-surgery. So 24 patients, and they found pretty much that no difference in the expression of cytokines, NSE or S100. NSE and S100 are serum markers of neuronal damage. The only finding that they found that potentially ketamine was protective in terms of an anti-inflammatory response was that the peak concentration of CRP was lower in patients that had been exposed to ketamine. There were absolutely no differences in the Bayley scale or any other evidence of neuroprotection in this pilot study. So then there's some data that says, well, maybe ketamine is actually damage-inducing. There's, again, some primate data that repetitive exposure to of ketamine in primates may induce neuronal apoptosis. And we know that NMDA receptors in the developing brain are expressed, and they're important in neuronal proliferation, migration, and maturation. And therefore, antagonists like ketamine may actually adversely affect brain development in infants and children. So one study really looked at this. This was a 2014 study that looked at repetitive exposures to patients with ketamine. These patients were having short procedures, usually 5 to 7 minutes of age, and they looked at the Bayley scales of infant development and, again, those neuronal serum markers. This was a prospective study. They enrolled patients that were 3 to 22 months of age. The ketamine dose here was much higher than the previous study, so it was 8 milligrams per kilogram, but the procedures were quite short. The interval between each procedure was between 3 and 4 weeks. And so they enrolled 52 patients. 20 of them had 1 ketamine exposure, 16 had 2, and 13 had 3 ketamine exposures. So they looked at their pre and post groups, and they found there was no difference between the groups prior to any ketamine exposures. However, they noticed that there was a significant increase in the S100 levels. Remember, that's that marker of neuronal damage after any exposure to ketamine as compared to the pre-ketamine levels. And interestingly, they found that after the third exposure, there were significant differences between the pre and post exposure testing in the Bayley scale for infant development. So a significant finding here. So we're going to talk a little quickly about sevoflurane. Sevoflurane we all use in our operating rooms. It's an inhaled anesthetic. It has a rapid onset of action. It's hepatically metabolized. And then there's Tiva. Tiva is we use in our operating rooms often for patients who have some sort of contraindication for inhaled anesthetics. It basically is a co-administration of an IV hypnotic and an opioid. Usually it's often propofol or remifentanil. Their uses are often, it's useful in preventing laryngospasm, and patients may have some decreased nausea or vomiting in the postoperative period. So one study kind of looked at, what is the difference between using Sevo and Tiva? This was a study looked at patients who were having tonsillectomies. It was a randomized block-controlled parallel group study done at a tertiary care center. 64 kids were randomly assigned to either getting Sevo or Tiva. The outcome of interest was something called negative postoperative behavioral changes. And this is really common in many children who have anesthetics. They include anxiety, sleeping disorders, fears, and uresis. And there's been several studies that have showed that the persistence of these negative behaviors can actually lead to long-term emotional and cognitive developmental issues. So this study basically did a validated post-hospitalization behavior questionnaire. This questionnaire was filled out by parents at post-op day 1, 3, 7, 15, and then actually 6 months even after surgery. Interestingly, they found that the proportion of negative behavior effects was significantly higher amongst patients who received inhaled anesthetic with the Sevo than those compared to those who are getting the Tiva. The other concerning factor is that the prevalence of these negative behavior factors was still high at 6 months of age. So they concluded that inhaled anesthetics saw more frequent, more prolonged negative behavior responses, particularly in the general anxiety, separation anxiety, and withdrawal and apathy categories. So our conclusion for our question 3 is that in patients that require general anesthesia, consideration of certain drugs, the use of certain drugs such as Sevo and ketamine really should be mitigated, and we should think about a little bit more widespread use of Tiva. This is a level B recommendation. So our last question is, what are the alternatives to general anesthesia? Spinal, regional. And then what is the data for their safety? So there's 6 studies that looked at this question specifically. Now, obviously, we have all used regional anesthesia. However, for certain techniques, the widespread use has been a little bit limited just because of experience. We see use of spinal anesthetics. It's commonly used in abdominal procedures, hernias, can be used for laparoscopy. Cottles don't provide any motor blockade, and they're good for procedures below the umbilicus, and they're easier to perform than a spinal. So Salim Islam, one of our members, compared the use of spinal anesthesia for laparoscopy and laparoscopic pyloromyotomy. It's a small study, 12 patients in each group, but they really noticed that there were no differences in the duration of surgery, the length of stay, complication, or the time to full feeds. There were, however, significantly and interestingly, a decrease in costs. So less time in the operating room actually allowed them to save over $1,200 per study. The GAS trial that Julia talked about really looked at 363 patients who were randomized to regional anesthetics. In those patients, compared to those who got general anesthesia, there was a decreased incidence of hypotension and a decreased incidence of early apnea. So some significant hemodynamic parameters that are beneficial in patients receiving regional anesthetics. A secondary analysis that looked at failures of those patients who were randomized to regional anesthesia but ended up getting general anesthesia, and they noted that a bloody tap on initial aspiration was the initial factor that was sort of a predictive of not being able to continue on with regional anesthesia. Talk quickly about DEX. Dexmedetomidine is a drug that we see very commonly used in the ICU. It's an alpha-2 adrenergic agonist and has minimal respiratory depression. Very interesting thing about DEX is that unlike many of the other anesthetic agents that we've talked about, it has no evidence in any animal model of any evidence of neurotoxicity. And there's actually some evidence that it may have a neuroprotective effect by attenuating the neuroapoptosis caused by other anesthetic agents. So there's one study that randomized patients who are undergoing inguinal hernia repair to DEX anacottle and SIVO anacottle. They randomized 51 patients to DEX and 48 patients to the general anesthetic arm. And they were able to find that with DEX-only anesthetic, that 46 out of 51 patients were able to undergo an inguinal hernia repair. And they found that there was significantly improved hemodynamic stability with DEX during the operation. So they found that there was no significant difference in the overall duration of anesthetic time, the total time spent in the operating room. There were no differences in perioperative adverse events or length of stay. And this use of DEX really negated the need for endotracheal intubation and any exposure to any general anesthetic agent. So our conclusion for question 4 is that regional anesthesia can be performed safely for selected cases and patients, and as new people are bringing in different types of blocks, those are things that we need to study further. The consideration of using regional anesthetic techniques with the addition of DEX may mitigate the risks of neurotoxicity and should be really considered as first-line therapy in selected short procedures. That's a level B recommendation. So just going back to the beginning and summarizing sort of our questions for this systematic review. Our first question was, does general anesthesia exposure in children pose a risk to their neurodevelopment? Though the data is mixed, and Julie did a wonderful job in going over that, we have to remember that the most robust studies suggest that a single anesthetic dose does not have any significant effects on neurodevelopment, autism, ADHD. So those are the answers you can give your families when they ask you. Our second question, is there a critical window? Should I have this done early? Should I have this done later? Data suggests that anesthesia may affect different domains of development at certain ages, but there's absolutely no conclusive data in the studies that we have now that waiting till someone is 3 years old or 4 years old to perform procedures that require general anesthesia. There's no evidence for that. And our third question, looking at the exposure to specific anesthetic agents, mitigating the risks, potentially using less ketamine, less SIVO. We should think about that, and using TIVA more often. And our fourth question is, can we use regional anesthetics? Yes, they can be performed safely and for selected cases, and we should think about using DEX as well. We are happy to answer questions at the end of the next session. We're going to turn it over to Akemi to talk about Hirschsprungs, or ASH, sorry.
Thanks. Nice. All right, good morning, everyone. For those that are kind of standing on the back and sides, there are a lot of seats up front here. You can filter in, and the benefit is then when Dr. Upperman takes your picture and tweets it out, everyone will know you were in the room when it happened. If you didn't get an audience response clicker, I encourage you to go pick one up. We have a couple audience response questions in this next portion. Now that Drs. Grabowski and Dasgupta have shown us that it's safe to put our kids to sleep, we're going to talk a little bit about what do we do when they are asleep, specifically for long segment Hirschsprung disease. Let's see. All right, there we go. All right. So our objectives in undertaking this review were to define what is long segment Hirschsprung disease, because I think the nomenclature is really mixed, to try and understand what are the preferred methods for repair of this disease, and then to try and appreciate the long-term outcomes for patients with long segment Hirschsprung disease, and try and describe any novel techniques or future strategies for treatment that we may be able to apply to our patients. So we conducted a PRISMA review. I won't go through the levels of evidence because the prior group already summarized that. But we looked at the literature from 1990 forward, and we defined 4 questions that align with our learning objectives. The first is really, what is the definition of long segment Hirschsprung disease, and how is it best determined? So for the first audience response question, the question is, what is your definition of long segment Hirschsprung disease? Is it proximal to the sigmoid and rectosigmoid up to the cecum, but not including total colonic aganglionosis? Is it proximal to the splenic flexure up to the cecum and not including total colonic? Is it total colonic or beyond? Is it proximal to the rectosigmoid, but including total colonic? Proximal to splenic flexure and including total colonic? Or is it something else? And I encourage people to come to the microphone at the end. So please, vote. I'm curious. All right. So most people say it's proximal to the splenic flexure, including total colonic aganglionosis. Let's see if they're right. So according to the literature, we found 33 studies that define this well in their approach. So as you see them left to right, there were 22 studies that define it as proximal to the sigmoid or rectosigmoid. There were 3 that defined it as proximal to the splenic flexure. And then there were 8 that defined it based on specific anatomic location, meaning they said, transverse colon or hepatic flexure or ascending colon. Okay. And so our recommendation from this is that we use the term long segment colonic, so not just long segment, but long segment colonic Hirschsprung disease is defined as aganglionosis that is proximal to the sigmoid colon and descending colon junction up to the cecum with ganglion cells present in the colon. So the next question is, does long segment Hirschsprung include total colonic aganglionosis? Again, there were 25 studies that addressed this. 4 of them included total colonic in long segment, quote unquote, and 21 did not, so they broke it out separately. So our recommendation is actually that total colonic is defined as no ganglion cells in the colon, but present in the terminal ileum, and that long segment colonic Hirschsprung disease does not include total colonic aganglionosis. Does total colonic aganglionosis include intestinal involvement? So again, 21 studies, 16 of them had total colonic including intestinal involvement, and 5 did not. And our recommendation from these studies is that total colonic does not include intestinal involvement beyond about 5 centimeters of the intestine, again, based on the literature. And that intestinal involvement beyond the terminal ileum should be called intestinal Hirschsprung disease. And total intestinal is defined as less than 20 centimeters of ganglionated intestine beyond the ligament of Treitz. We aggregated all of the studies that had details, so 22 studies, 2,350 patients, and looked at what length of disease did those studies include. And so this is here for your reference, but about 75% of patients have short segment Hirschsprung disease, 15% have long segment, 8% have total colonic, and just over 1% have total intestinal. This will be in the manuscript. So we propose, and this is a grade C recommendation, 2 options. So the first is we abandon ultra-short segment as a term because there's no clear definition. It's highly variable in the literature, and we say we should abandon the usage. Short segment should be aganglionosis up to the sigmoid colon descending colon junction. Long segment colonic is aganglionosis from the sigmoid colon descending colon junction up to the cecum, but with ganglion cells present in the colon. Total colonic is aganglionosis of the entire colon and less than 5 centimeters of the terminal ileum. Intestinal extends into the terminal ileum and beyond more than 5 centimeters. and total intestinal is less than 20 centimeters of ganglion intestine. However, we think, based on our committee's review as well as consultation with the Hirschsprung disease interest group and many experts in the field, that we should really, as a group, as a specialty, move towards precise specification of anatomic location. Meaning, rather than calling it total colonic or long segment colonic, really say where are the ganglion cells, rectum, sigmoid, descending, etc. And so, with that, second audience response question. Which would you prefer, and which would you use? The first, which is the segment-based definition, or would you prefer to use a precise anatomic specification or something else? Please vote. Fantastic. We agree. All right. So then the next question becomes, how do we best determine that there's long segment Hirschsprung disease preoperatively? So this is not well addressed in the literature. There are 4 studies that we came across, and there's a little bit of overlap. So there's some subjective features that radiologists may identify on contrast enema. Normal appearing colon, that may be a feature, small or microcolon, meconium plug or comma-shaped colon, and then flattened or hepatic or splenic flexures. Specifically, the rectosigmoid index, as we all know, normal is greater than 1, so the rectum is bigger than the sigmoid in diameter. In Hirschsprung disease, it should be less than or equal to 1. The rectosigmoid index was not suggestive of Hirschsprung disease in the 2 studies that addressed it. Looking at the radiographic transition zone, so 1, if a radiographic transition zone is not seen immediately, consider the study used 24 or 48-hour delayed films to try and identify a transition zone. So if the contrast enema shows a rectosigmoid transition zone, 90% of those patients will have short segment disease, but 10% of those patients will have long segment disease. None of them, at least in this study, had total colonic. If the contrast enema shows long segment radiographic transition zone, all of them will have long segment disease, 71% long segment colonic and 29% total colonic. And if the contrast enema shows no radiographic transition zone, 75% of those patients will have short segment disease. 12% will have long segment disease, and 12.5% will have total colonic aganglionosis. And so from this, we recommend that contrast enema should be obtained preoperatively. There are specific features that may suggest total colonic aganglionosis. The rectosigmoid index is not of value in diagnosing long segment disease. That we should consider delayed films if the initial study is quote-unquote normal or fails to demonstrate a radiographic transition zone, and that, however, the radiographic transition zone poorly correlates with the length of aganglionosis in total colonic and long segment disease. In addition, and we'll elaborate on this in the manuscript, we suggest that laparoscopic or transumbilical biopsy should be obtained to confirm the level of aganglionosis prior to starting any anal dissection. And I think this was discussed robustly on Sunday's colorectal session. So the next question then is, what's the preferred method? So we have the diagnosis. How do we fix these children? So to survey the audience, what is your preferred method for surgical repair of long segment colonic Hirschsprung disease? Is it the Swenson operation, the Suave, and choose whichever one is closest to what you actually do. Duhamel, Martin procedure, Kimura procedure, an ileal pouch anal anastomosis, a permanent stoma, or something else. And again, this is long segment colonic, not total colonic, or beyond. All right, so most would choose the Suave procedure, and second is the Swenson. It's very interesting. How about for total colonic disease? Same choices, same list of operations. What would you choose? Can we switch to the audience response thing? There we go.
It's going to go long. Yeah, what? It's going to go long. Mine's about 10. Yours is about 10. About 10. I'm going to try and go quickly, right?
All right. So an even split between the Martin or an ileal pouch anal anastomosis. Very interesting. Or sorry, the Duhamel or an ileal pouch anal anastomosis. All right. Fantastic. Let's see what the literature says. So we already listed the options after leveling and biopsy for long segment total colonic or intestinal disease, primary repair or leveling ostomy. And there's a variety of techniques. The literature is, again, vague. So there are 20 studies that we identified that clearly describe the level of aganglionosis and the type of operation performed. All of them are retrospective case series. None of them have any control groups or study design that allows us to compare one operation to the next. Okay? We tried to aggregate some of the data. So on the left are the various techniques and the number of papers that address that technique and the number of patients included in the studies. And there's some findings with each of the specific techniques. So for Duhamel, for example, many of the papers noted an incidence of incontinence, which is greater than 40%. However, this is not specific to the Duhamel operation. For Martin's procedure, or the left colon patch, many papers remarked that it was technically difficult compared to the Duhamel or Suave, and that there's the concern for long-term dilatation of the colonic pouch requiring revisional surgery. The Suave and Swenson, the outcomes appeared similar to the Duhamel operation, but stool frequency decreases after ileal adaptation, which is a concern leading into it. For the right colon pouch, this is primarily used in intestinal disease. And again, long-term dilatation, similar to the Martin procedure, requires revisional surgery. For an ileal anal, with or without a pouch, there's a defined failure rate and need for revision. And then, of course, small bowel transplantation has been described for patients with total intestinal disease, but this appears to be rare because of advances in intestinal rehabilitation, and again, is only really appropriate for the total intestinal population. And so what is the preferred method? A recommendation that there's insufficient evidence to recommend a preferred method for surgical repair of long segment disease, and that we as a society really should consider prospective studies comparing operative options based on relevant long-term outcomes. And so to speak about what are those relevant long-term outcomes, Dr. Kawaguchi.
Thanks, Ash.
Absolutely.
So what are the long-term outcomes for patients with long segment Hirschsprung disease? And this is actually a fairly hard question to ask. So we identified 22 papers in the literature that stratified patients according to long segment, short segment, and total colonic aganglionosis. But only 10 out of these 22 papers specifically identified outcomes for patients with long segment Hirschsprungs. 9 papers addressed patients with total colonic aganglionosis, and 10 papers reported on quality of life for patients with Hirschsprung's disease. But out of these, only 7 papers specifically spoke about long segment. So the outcomes examined had variable definitions within the literature as well. Normal bowel movements were defined as no soiling and not requiring medications or enemas. Constipation, straining, bowel movements less than 3 times per week, incomplete evacuation of stools, or needing medications to facilitate stools. Soiling and incontinence were commonly grouped together within the literature, and Hirschsprung's associated enterocolitis, we all know, have a lot of definitions, but generally abdominal distension, diarrhea, emesis, blood in the stool, or explosive bowel movements were defined as enterocolitis. So looking at the summary of those 10 papers that specified long-term outcomes for patients with long segment disease, they're found to have increased soiling and incontinence, but overall this improves with time, increased stool frequency in looser stools, which makes sense as they have less colon, and a higher rate of Hirschsprung's associated enterocolitis as well. Now, looking at total colonic aganglionosis, that was a little bit easier as there's 9 papers that identified outcomes for patients with total colonic aganglionosis. And I know this is a busy slide. I'm going to summarize it on the next slide, but I want to show that there's a lot of variety in how people choose to do surgeries for this, as well as a lot of combination of soiling and incontinence in the literature. To summarize these 9 papers, the Duhamel was actually the most common definitive surgical procedure for total colonic aganglionosis. However, a lot of these patients had multiple surgeries, and most often this was because they had an incorrect level of aganglionosis prior to their definitive surgery. Soiling and incontinence were common, as well as Hirschsprung's associated enterocolitis. The number of bowel movements per day reported was anywhere from 1 to 6. Generally, it was more as the patient was younger, and then got less and less as the patient got into their adolescent and teenage years. Loose stools, however, in this population can be a very big problem, which leads to perianal excoriation and electrolyte problems and even nutritional difficulties. In some of those papers, up to 20% of those patients actually ended up with a permanent ostomy due to these problems. In terms of quality of life, there were 10 papers, and again, 7 of those differentiated in between level of aganglionosis. And for quality of life outcomes, the majority of these papers did compare Hirschsprung's patients to normal age-matched controls. And in comparing them to normal age-matched controls, for long segment, there was increased abdominal symptoms, increased incontinence, and an equal rate of constipation. They did not compare short to long segment, though, in these papers. And then a psychosocial domain, more of an emotional and well-being, school performance, that there was an overall quality of life comparable for Hirschsprung's patients to controls. However, quality of life was directly related to patients having a lower score if they had incontinence problems. And since our patients with long segment disease have a higher rate of incontinence, they actually had lower overall quality of life scores. So in terms of long-term outcomes, it's difficult to determine through the literature because there's often not a separation between short and long segment reported in the literature. For total colonic aganglionosis, there are increased rates of incontinence, Hirschsprung's-associated enterocolitis, as well as a potential need for reoperations. And what I want to stress is that longitudinal follow-up for these patients is really needed because once patients have had their definitive surgery, they're not necessarily all well. A lot of these patients still have problems and need to be managed by someone who's familiar with Hirschsprung's disease. And then the next question, the last question, was what novel techniques exist? What future strategies are being developed for the treatment of long segment Hirschsprung's disease? Unfortunately, there really aren't very many novel techniques. Basically, all the papers have used techniques that were already discussed. We wanted to highlight a couple things. The myectomy, myotomy, and transanal decompression were 2 techniques. So this is not a new technique, but I thought it warranted mention. This is first described by Dr. Ziegler in 1987 for patients who have intestinal aganglionosis, so a very short segment of ganglionated bowel. It involves a myotomy of about 10 centimeters of a 1 centimeter strip of bowel, and then myectomy of 1 centimeter strip of bowel, and then a myotomy along the antimesenteric border of the aganglionic bowel, and that can be brought up as an ostomy. While some patients did have improved enteral tolerance, and some people even got off of TPN, there were a lot of patients who had difficulties with sepsis due to intestinal bacteria and leakage, so it's not often done. And then one preoperative thing that can be done, which I thought was interesting, is this is for patients with long segment Hirschsprung's or total colonic aganglionosis. This study used a transanal rectal decompression tube, which is actually done as an outpatient in these patients, and we're able to delay surgery for a mean of 65 days, but anywhere from 2 weeks to 4 months. And then they did a definitive surgical procedure, and these patients did very well with no episode of enterocolitis, no abdominal distension, and they did a primary pull-through with no ostomy. One of the other things that has come up is, do probiotics help in the prevention of Hirschsprung's-associated enterocolitis? There are 2 randomized controlled studies with 30 in each arm, and they compared the use of probiotics versus a placebo, and they had conflicting results. So the first study found a 24% rate of Hirschsprung's-associated enterocolitis, and for both long segment and Hirschsprung's disease and short segment Hirschsprung's disease, it did not change the rate of enterocolitis. The paper by Wang et al. Did show not only a decrease in Hirschsprung's associated enterocolitis, but also a decrease in the severity, and also a decrease in pro-inflammatory biomarkers and a decrease in anti-inflammatory biomarkers. And while they didn't specifically specify long segment or Hirschsprung's in this study, they did have equal amounts of long segment in each group. But I think the most exciting novel treatment or up-and-coming treatment for Hirschsprung's disease would be cell-based therapy. So using the potential for cell-based therapy to generate an enteric nervous system in the aganglionic bowel is one way that we could possibly treat Hirschsprung's disease. This can be done with embryonic stem cells or iPS cells. I know that there have been animal models that have actually worked and have been shown to be able to generate an enteric nervous system. And I know that some human studies are in the near future for this as well. This is being done by many of our APSA members who are listed here, and it's very exciting. So there is a lack of evidence to support any novel techniques, as there really aren't any in the literature. The emphasis should be placed in development of future strategies such as cell-based therapy. And these are just a summary of our summary slides, but the basics are that we need to, I think Ash provided a very good definition of what we could use for long segment versus short segment, but a preferred thing would be to use the anatomic location of the level of aganglionosis. There is no specific surgical procedure that works best for Hirschsprung's disease, for long segment Hirschsprung's disease. I think the most important thing in the long-term outcomes is that these patients do need longitudinal follow-up because they do have issues with incontinence and enterocolitis. And that although there are no new surgical techniques, it's very exciting, hopeful developments in the cell-based therapy for Hirschsprung's disease.
Yeah. I think the key really is that the literature is so mixed because the nomenclature is mixed. And if we as a group can agree on a definition, then we can really advance the field. The APSA Hirschsprung Disease Interest Group just published a paper describing synoptic reporting for surgery and pathology, which hopefully will help us standardize our definitions. When we publish the manuscript related to this review, that'll reinforce that. But then we can start comparing apples to apples and really studying this longitudinally. And I think that some of the research consortiums that our society has already started, the Midwest Pediatric Surgical, the Peds Surgical SRC, the Peds Colorectal and Public Learning Consortium, these types of groups are going to be able to bring together patients for a rare disease around the world and help us define how to care for these children better.
I think we'd like to open the mics to questions for both presentations.
I was trying to be quick. Oh my God. Can't really see anything.
Andrea Bishop, Children's Colorado. I just have a question about the Hirschsprung portion. What's the difference between the ilioanal without a pouch and the Swenson for total colonic aganglionosis?
That's a great question. They're probably the same operation, but the papers don't really describe them well, right? So many of the papers describe an ilioanal anastomosis, but if you read the methodology, what they're describing is a Suave. Some of them describe that operation, and what they're describing is a Swenson. Some of them describe it, and the anastomosis is way higher up than any of us would consider as a Suave or a Swenson. And so the literature is very mixed.
Dr. Pena.
If you allow me to make a comment, I don't have a question, but obviously we are not curing total colonic aganglionosis. It's a condition that is still a challenge for all of us. And I strongly recommend to follow the patients for many years to see actually what's happening to these patients. And obviously the conclusion is no, we are not curing them. And I am biased against the patches and pouches because I have been removing many of those patches and pouches. What we are trying to do is to cheat on Mother Nature we're trying to create a reservoir, and we try producing stasis in the small bowel, and small bowel was created by nature to have a fast transit, and when we slow down, the consequences are secretory diarrhea, inflammatory changes of the mucosa, and the patients get actually worse. And another thing that we have learned is that we never close the ileostomy in these patients before the age of toilet training. When you take a baby with an ilioanal anastomosis, with or without a pouch, and you close the stomach, the patient suffers the worst diaper rash that you can ever see. And that's why if you do a very good surgical technique, you keep the patient with the ileostomy open, which bothers a little bit the parents, but the patients are happy. And we close the ileostomy when the baby is already toilet trained for urine, verbalize the desire to go to the toilet, and then the patients become toilet trained very fast. babies without the colon, with liquid stool and frequent bowel movements, don't know how to control the little babies, and they have that terrible diaper rash. Our approach is not very popular because we pediatric surgeons like to brag and say that I finished the treatment at 1 month of age. You do it 2 weeks, 1 week prenatal. We are competing in that sense. But actually, it's much better for these babies to stay with ileostomy by the age of 3.
Thank you, Dr. Pena. I can't see because the lights
David
is over.
Rothstein, Buffalo. Question about anesthetic exposure. I think one of the things we pride ourselves on is coordinating care. So families have 2 different procedures, 2 different services. We say, we'll work it out somehow. It's inconvenient, but the truth is that the total duration of anesthesia is more than the sum of 2 individual anesthetics. You never get it timed just right. So would you recommend that we abandon this in order to decrease the total exposure, or favor decreasing iterative or multiple exposures?
There's actually not any good data on, like the best data is just on a single exposure. Some of the level 3 and 4 studies look at multiple exposures, and it looks like multiple exposures is worse. So combining them is probably okay, but it depends on the total duration. So I don't know necessarily, based on the available literature, that it makes that much sense to definitely try to combine, but the multiple exposures has panned out to be a little bit more of an issue than just the single exposure. It's like a bad answer.
Can't see.
Langer from Toronto. 2 comments. One, I was very surprised that so many people are using what I assume is a J pouch for total colonic Hirschsprungs, because there really isn't much in the literature, and most of it comes from Scandinavia, and there's not a lot of long-term follow-up. And what I would suggest is that the potential advantage of that is that you have a little bit of a reservoir there, but the Duhamel, a short Duhamel, not a Martin, but a short Duhamel, gives you the same kind of reservoir. It's a much easier operation, and I think safer because you don't have to resect the whole rectum. So that's the first thing. And the second thing, I'd like to disagree with Dr. Pena, respectfully, because I really don't think you need to wait until kids are 3 years old to close their stoma. What we've done is used the consistency of the ileostomy effluent as a guide to when it's time to do the pull through and get rid of the ileostomy. And once the ileostomy effluent is thick and pasty, those kids generally do very well. They often need some loperamide, but they usually do very well from the point of view of the perineal excoriation. And the other thing that's advanced in recent years is our the ability for our nurses primarily to manage those perineal skin problems. And so I really don't think in this day and age that's necessary to wait till they're 3.
So thank you, Jack, for that comment. I'm going to push back on your first statement a little bit. I think that your comment about Duhamel versus ileal pouch or any of the other options is valid. And I think, based on our review of the literature and what's out there and published, is that the best operation is probably the operation you do best. So one operation is not necessarily better than the other. But I think the real take-home is when you have 7 different operations for the same disease, we haven't figured out that disease. And so we have a lot of work to do as a society.
That's all we have for questions. That's it.
Bobby, Baton Rouge, Louisiana. Regarding the literature on total colonic Hirschsprung's disease and the comments made by the experts, what does the literature say about timing of Duhamels or J pouches for total colonic Hirschsprungs?
Yeah, so it doesn't. It's not well addressed in the literature, and there's a spectrum that's represented by what Drs. Pena and Langer said. So there are many papers that say wait for definitive reconstruction or to close an ostomy until after the children are toilet trained for urine, and then toilet train them for a stool second. And there are others that say it's safe, et cetera, to do as an infant.
Even in the newborn period.
Okay, I want to thank everybody. It's the end of the session. It's already 8:30. I want to especially thank the team who did this work. This represents review of thousands of abstracts, even though it only comes down to a handful of manuscripts. and hours of work getting all this together to present to all of you. So thank you to the team for doing this work, and thank you everybody for coming.